What do we mean by rheumatoid arthritis? Anyone can say? It's an autoimmune disorder and it specifically affects the joint, causing joint inflammation, right? So, rheumatoid arthritis is an autoimmune disease causing joint inflammation, synovial proliferation and destruction of the articular cartilage. It's a chronic, progressive, crippling disorder with a waxing and waning course. Waxing and waning course মানে কখনো ইনফ্লামেশনটা বাড়বে, কখনো রেমিশনে চলে যাবে। So it's having waxing and waning course. What happens here? Basic pathophysiology. The immune complex composed of IgM, they activate complement, and what happens? They cause release of cytokines, mainly TNF-alpha and interleukin-1. TNF-alpha is the major inflammatory mediator of rheumatoid arthritis. So mainly TNF-alpha and IL-1, which are chemotactic for neutrophils. So these inflammatory cells secrete lysosomal enzymes which damage the cartilage and erode the bone. And while prostaglandins produced in the process cause vasodilation and pain. Now, while we are treating a patient of rheumatoid arthritis, there should be some goals. What we are going to achieve? The first goal is to reduce the pain and the stiffness of the joint, ameliorate the pain, swelling and joint stiffness. That's the short term goal. The next goal is prevent articular damage, articular cartilage damage and bony erosions. So we are going to treat the basic pathophysiology, and the long term goal should be to prevent the joint deformity and preserve the joint function. So these are the goals for the treatment of rheumatoid arthritis patient. Now coming to anti-rheumatic drugs. Before that, to ameliorate the pain, swelling and joint stiffness, what we use NSAIDs or the corticosteroids. But to prevent articular cartilage damage, bony erosions and preserve the joint functions, basically we use anti-rheumatic drugs. Now what are anti-rheumatic drugs? Anti-rheumatic drugs are the drugs which suppresses the rheumatoid process. That means they are basically counteracting the basic pathophysiology of rheumatoid arthritis. So the suppressed rheumatoid process brings about a remission and retard disease progression, but they do not have non-specific anti-inflammatory action. Corticosteroids are not included in anti-rheumatic drugs as they have got non-specific anti-inflammatory action. Now these anti-rheumatic drugs, they are also called DMARD or disease modifying anti-rheumatic drugs, or SAARD, that is slow acting anti-rheumatic drugs. Now they act over a few months of onset of treatment, and after the drug is stopped, the disease may relapse after a few months. Now along with DMARD, basically anti-rheumatic drugs, some biological agents have been developed recently, like TNF-alpha receptor antagonist. They have been added for resistant cases. So coming to the classification of anti-rheumatic drugs, these include non-biological drugs and the recent added biological agents. These non-biological drugs, they are divided into immunosuppressants and most commonly used, and the other immunosuppressants. So that include methotrexate, azathioprine, cyclosporine, sulfasalazine, chloroquine or hydroxychloroquine, leflunomide, tofacitinib, baricitinib. Now methotrexate is the drug of choice of among the DMARD in the patients of rheumatoid arthritis. Biological agents include TNF-alpha inhibitors that include infliximab, etanercept, adalimumab, and other biologicals. They include anakinra, which is IL-1 receptor antagonist, abatacept, rituximab. Adjuvant drugs, they include corticosteroids. Now, coming to the non-biological DMARD. The drug of choice, as said earlier, methotrexate. Now, methotrexate we know is an anti-cancer drug, but it is also used in rheumatoid arthritis. How they are acting? They basically inhibit dihydrofolate reductase. They are dihydrofolate reductase inhibitor and have got prominent immunosuppressant and anti-inflammatory drug property. They cause inhibition of cytokine production, chemotaxis, cell-mediated immune reaction. Also, the proliferation of immune inflammatory cells are inhibited. Oral bioavailability variable may be affected by food, excretion enhanced in renal disease, so not recommended for such patients. Induction in the as anti-cancer therapy, the drug is used daily, but in a patient of rheumatoid arthritis, methotrexate is used as a once weekly dose in low dose of once weekly regimen. So, induction of oral low dose weekly methotrexate regimen has improved acceptability. Now, preferred for the initial treatment of rheumatoid arthritis, it is now the DMARD of choice. Why? As the onset of action is relatively rapid among other DMARD, it is around 3 weeks to 6 weeks. Number 2, response is more predictable and more sustained response over long term. These are the reasons why methotrexate is the first line agent among the DMARD. Combination regimen of 2 or more DMARD mostly include methotrexate unless contraindicated or intolerant. Now, drug interactions, probenecid and aspirin, they increase the level of methotrexate. Trimethoprim again is a DHFR inhibitor, so the bone marrow suppression may be exaggerated. Side effect, oral ulceration and gastrointestinal upset are the major side effects. Liver injury may occur, causing cirrhosis in some patients with prolonged therapy. Incidence of chest infection may be increased. Contraindicated in pregnancy, lactation, liver disease, active infection, leukopenia and peptic ulcer. Now, coming to the second drug, azathioprine is a purine synthase inhibitor. It is a prodrug in the body. It is converted to 6-mercaptopurine and by the enzyme thiopurine methyltransferase. Is a potent suppressant of cell-mediated immunity like that of methotrexate. Appears to selectively affect differentiation and function of T cells and natural killer cells. Remission is induced in smaller percentage of rheumatoid arthritis patients. So, efficacy is lower than that of methotrexate and is less commonly used. It is generally not combined with methotrexate. Why? The side effects are exaggerated. Given along with corticosteroids, it has a steroid sparing effect. Coming to the next drug, sulfasalazine is basically suppresses the disease in significant number of rheumatoid arthritis patients. Mechanism not properly known. Basically in the colon, the drug is split into 2 moieties, sulfapyridine and 5-amino-salicylic acid. Of them, sulfapyridine is absorbed systemically and possibly is the active moiety in rheumatoid arthritis patient. Generation of superoxide radicals and cytokine elaboration by inflammatory cells may be suppressed. Efficacy modest in rheumatoid arthritis and side effect unpleasant. Neutropenia, thrombocytopenia may be seen in some group of patients. So, regular blood count is necessary in patients receiving sulfasalazine, used as a second line drug for milder cases or may be combined with methotrexate. Sulfasalazine is also used in inflammatory bowel disease. Now, there the 5-amino-salicylic acid broken down from the sulfasalazine in the colon, that is the active moiety, that is not absorbed and act locally in the colon. Hydroxychloroquine or chloroquine is basically an anti-malarial drug used in malaria. Now, this drug has found efficacy in rheumatoid arthritis patient also. Although the efficacy is lower, it induced remission in up to 50% of the patient, but take 3 to 6 months. Relatively low toxicity, but efficacy also low, and it does not prevent bone erosion. Now, mechanism of action not known, found to reduce monocyte IL-1 and thus inhibiting B lymphocyte. Antigen processing may be interfered, lysosomal stabilization and free radical scavenging are possibly the other mechanism. Now, drug has to be given for longer periods for active. Now, problem is that on longer uses the drug gets accumulated in many tissues, particularly melanin containing tissues, and what happens, that lead to retinal toxicity and corneal opacity. So, but among chloroquine and hydroxychloroquine, this effect is lower with hydroxychloroquine and is reversible. That is why hydroxychloroquine is preferred in rheumatoid arthritis patient over chloroquine. That is one of the questions asked in exams. Why hydroxychloroquine is preferred in rheumatoid arthritis patient over chloroquine? The reason is the side effect, ocular toxicity is lower and reversible. Other adverse effects are rashes, graying of hair, irritable bowel syndrome, myopathy, neuropathy. It is employed in milder non-erosive cases. Kano erosion ta prevent kore na. It is employed in milder non-erosive disease, especially when only one or a few joints are involved, or they can be combined with methotrexate and sulfasalazine. Leflunomide. Leflunomide inhibits proliferation of stimulated lymphocytes in patients with active rheumatoid arthritis. Arthritic symptoms are suppressed and radiological progression retarded. Efficacy comparable to the methotrexate. Onset of action comparable to methotrexate, around 4 weeks. Rapidly converted in the body to an active metabolite which inhibit dihydroorotate dehydrogenase. Antibody production by B cells may be depressed. Active metabolite has a long half-life of 2 to 3 weeks. Now, adverse effects are diarrhea, headache, nausea, rashes, loss of hair, thrombocytopenia, leukopenia, increased chances of chest infection. Generally, methotrexate and leflunomide, they are not combined because chances of hepatotoxicity will be more. They can be combined with sulfasalazine to improve benefit. So, what is the drug of choice in rheumatoid arthritis patient among the DMARD? Methotrexate. What the common toxicity with methotrexate? Mucositis, oral ulceration and GI upset, gastrointestinal toxicity. These are the major, these are the common, and the major is hepatotoxicity. Okay. Coming to the biological agent, the several recombinant proteins, monoclonal antibodies that bind to and inhibit specific cytokines, especially TNF-alpha or interleukin-1 have been produced. They have been found to afford substantial benefit, high efficacy in autoimmune disease like rheumatoid arthritis, inflammatory bowel disease, psoriasis, scleroderma. They are expensive, side effects are very high, prominent adverse effects. They are the reserved drugs for severe refractory case. So, among the TNF-alpha inhibitors, these are the preferred biologicals in rheumatoid arthritis patient because TNF-alpha is the major inflammatory mediator in rheumatoid arthritis. So TNF-alpha plays a key role in the inflammatory cascade of rheumatoid arthritis by activating membrane-bound TNF-alpha receptor 1 and 2 on the macrophage T cells. TNF-alpha inhibitors administered can neutralize and interrupt the reaction. They mainly suppress macrophage and T cell function. Inflammatory changes in the joints and the synovial tissues and new bony erosions are slowed. Quicker response than the non-biological agent, effective as monotherapy, generally added with methotrexate when response to methotrexate is not adequate or in rapidly progressive cases. The problem is susceptibility to opportunistic infection, particularly tuberculosis and also pneumocystis carinii pneumonia. Infliximab among the TNF-alpha inhibitor is a chimeral monoclonal antibody administered intravenously. Chimeral monoclonal antibody mane royeche basically the antibody here has been created using the genes of human and the mouse. So infliximab is a chimeral monoclonal antibody administered intravenously. Etanercept is a recombinant fusion protein of TNF-alpha receptor with Fc portion of IgG1 administered subcutaneously, while the adalimumab is a recombinant human monoclonal anti-TNF-alpha antibody administered subcutaneously. Coming to corticosteroids, corticosteroids basically is a potent, non-specific immunosuppressant and anti-inflammatory drug. Can be included at any stage in rheumatoid arthritis with the first or the second line drug if potent anti-inflammatory action is required. Symptomatic relief, prompt relief, but they do not arrest the rheumatoid process, though bony destruction and bony erosion may be slowed. Long-term use causes severe disadvantages. Either low doses are used to supplement NSAID for the symptomatic relief, or high dose can be tapered down quickly. In case of single or few joint involvement with severe symptom, intra-articular soluble glucocorticoid injection can be used. Now coming to the Euler recommendations for rheumatoid arthritis patient, 2022 is the year when the guidelines were published. How to treat a patient of rheumatoid arthritis. Therapy with DMARD should be started as soon as the diagnosis is made. Treatment is aimed at reaching a target of sustained remission with low disease activity. মানে আমার টার্গেট কি থাকবে, যাতে পেশেন্টটা কিন্তু ডিজিজ রিমিশনে চলে যায়, কোনো জয়েন্টটা ইনভলভ নেই, কোনো পেন নেই, ইনফ্ল্যামেটরি মার্কার্সটা রিডিউস করে যাবে। মনিটরিং ফ্রিকুয়েন্ট ইন অ্যাক্টিভ ডিজিজ এভরি 1 to 3 months. Methotrexate should be the part of first treatment strategy. Now in case of methotrexate contraindication or intolerance, leflunomide or sulfasalazine should be considered. ঠিক আছে? Now short term glucocorticoid should be considered when initiating or changing CSDMARD. Now এই গাইডলাইনে DMARD কে তিনটে ভাগে ডিভাইড করেছি। একটা CSDMARD or conventional synthetic DMARD like methotrexate, leflunomide, sulfasalazine, hydroxychloroquine. These are all basically CSDMARD, conventional synthetic DMARD. BDMARD, that is biological DMARD, that include TNF-alpha receptor antibody, interleukin-1 receptor antibody and others. And the third one is TSDMARD, that is targeted synthetic DMARD, that includes mainly genus kinase inhibitors like tofacitinib, baricitinib and others. These are the newer synthetic DMARD. Now if the treatment target is not achieved with the first CS, that is conventional synthetic DMARD strategy, and in the absence of poor prognostic factor, the other conventional DMARD can be added up. তো একটা দেওয়া হয়েছে, রেসপন্সটা পুরোপুরি অ্যাচিভ হয়নি, আমি সেকেন্ডটা দিতে পারি, we can combine second, third if needed. Biological DMARD or TS DMARD should be combined with a CS DMARD in patient who cannot use CS DMARD as co-medication. একটা কনভেনশনাল DMARD যে আছে লাইক methotrexate, তাতে পুরো রেসপন্স আসেনি, সেকেন্ড সি কনভেনশনাল DMARD দেওয়া যাবে না, সেখানে কিন্তু we can prefer biological or the targeted synthetic DMARD. If a biological or targeted synthetic DMARD has failed, treatment with another biological DMARD or a targeted synthetic DMARD should be considered. After glucocorticoid have been discontinued and patient is in sustained remission, dose reduction of DMARD may be considered. কারণ disease activity টা low হয়ে যাবে, patient is in remission, we can reduce the dose of DMARD as needed. Now coming to the gout. Gout মানে basically the primary pathophysiology is metabolic disorder leading to hyperuricemia, that the urate crystal deposit in the joint causing joint inflammation. Okay, so gout is a metabolic disorder characterized by hyperuricemia. Uric acid is a product of purine metabolism having low water solubility, especially at acidic pH. Excess uric acid hence precipitate and gets deposited in joint, in the kidney and in the tissue causing tophi. Now, secondary hyperuricemia can occur in leukemias, lymphomas, polycythemia, particularly when treated with chemotherapy or radiation, because this is due to enhanced nucleic acid metabolism and uric acid production. And again, hyperuricemia can be drug induced like thiazides, furosemide, pyrazinamide, ethambutol, levodopa. They decrease the excretion of uric acid. Now, what are the drugs used for the gout? It can be used for acute gouty arthritis, that include NSAIDs, non-steroidal anti-inflammatory drug, colchicine is specific for gouty arthritis, and glucocorticoids. Chronic gout or hyperuricemia, the drug uricosuric can be used, which increase the excretion of uric acid in urine, like probenecid, sulfenpyrazone. The uric acid synthesis inhibitors can be used like allopurinol, febuxostat. So these are the drugs used in gout patient. Acute gouty arthritis manifests as sudden onset of severe inflammation in a small joint due to precipitation of urate crystals in the joint space. Most common joint involved is first metatarsophalangeal joint of the great toe. An acute attack of gout is started by the precipitation of urate crystals in the synovial fluid. On being engulfed by the synovial cells, they release mediators and start an inflammatory response. Chemotactic factors are produced, the granulocytes migrate into the joint, they phagocytose urate crystals and release a glycoprotein which aggravates the inflammation. Joint become red, swollen and extremely painful and requires immediate treatment with an anti-inflammatory drug without attempting to lower blood urate level. Mind it, একটা acute gouty arthritis মানে একটা swollen joint নিয়ে এসছে because of acute gouty arthritis, তাকে কিন্তু urate lowering drug initially দেওয়া উচিত নয়। প্রথমে যেটা করি আমরা, প্রথমে একটা ড্রাগ দিই to decrease the inflammation, to ameliorate the pain and inflammation. কমে যাওয়ার পর আমরা বেসিক্যালি uric acid lowering ড্রাগটা দিই in covered with an anti-inflammatory drug. কেন আগে কেন দিই না? তাতে কিন্তু acute gouty arthritis আরো বেড়ে যেতে পারে। ঠিক আছে, তো without attempting to lower blood urate level. When acute attack subsides, urate lowering therapy is instituted and anti-inflammatory cover is continued for several weeks. If hyperuricemia is not controlled, attacks recur and involve many joints, resulting in chronic deforming arthritis. So coming to the drugs used in acute gouty arthritis, that include NSAIDs, the drug of choice here, one of the strong anti-inflammatory drug For example, naproxen, piroxicam, diclofenac, indomethacin or etanercept. Of them, naproxen and piroxicam are more preferred because added advantage they decrease the migration of they decrease the chemotaxis of the granulocytes. Extra advantage. They are given in relatively high and quickly repeated doses, quite effective in terminating the attack, but may take 12 to 24 hours time, and complete resolution occurs in 5 to 10 days. Response slower with colchicine, but it is not preferred because of high toxicity. NSAIDs are preferred. Response slower than with colchicine, but better tolerated. Majority of patients prefer NSAIDs over colchicine. Their strong anti-inflammatory effect is responsible for benefit. Naproxen and piroxicam specifically inhibit chemotactic migration of leukocytes into the inflamed joint. After the attack is over, NSAID should be continued at lower doses for next 3 to 4 weeks, while drugs to control hyperuricemia takes effect. মানে ইনফ্লামেশনটা কমে যাওয়ার পর আমি ইউরিক অ্যাসিড লোয়ারিং ড্রাগটা দেব, তার উপরে কিন্তু একটা NSAID কভারটা রাখবো for next 3 to 4 weeks. Colchicine is an alkaloid obtained from the plant Colchicum autumnale. It is neither analgesic nor anti-inflammatory, and it has got specifically action on the gouty arthritis. So, but it specifically suppress gouty inflammation. So, it can be basically একটা পেশেন্ট ইনফ্লেমড জয়েন্ট নিয়ে এসছে, যদি কলচিসিন দেওয়া হয় and the inflammation suppresses, then the inflammation is due to acute gouty arthritis. It can be diagnosed. It is such specific, but it specifically suppresses gouty inflammation. It does not inhibit the synthesis or promote the excretion of uric acid. It does not affect phagocytosis of urate crystals, but inhibits release of chemotactic factors and of the glycoprotein, thus suppressing subsequent events. By binding to the fibrillar protein tubulin, it inhibits granulocyte migration into the inflamed joint. Other actions are antimitotic and inhibiting of gut motility. Rapidly absorbed orally, partly metabolized in liver, excreted in bile, undergoes enterohepatic circulation. Ultimate disposal occurs in urine and feces over many days. The inhibitors of CYP3A4 retard colchicine metabolism and increase toxicity. Toxicity is high and dose related, mainly gastrointestinal, causing nausea, vomiting, watery or bloody diarrhea and abdominal cramps. In overdose, kidney damage, CNS depression, intestinal bleeding and death may occur due to muscular paralysis and respiratory failure. It is the fastest acting drug to control an acute attack of gout, but second line option because of higher toxicity. The drug of choice in acute gouty arthritis is not colchicine, it is non-steroidal anti-inflammatory drug. Intra-articular injection of a soluble steroid suppresses symptoms of acute gout, indicated only when a single or few joints are involved, and in those not tolerating NSAID or colchicine. Systemic steroids are rarely used, highly effective and produce nearly as rapid a response as colchicine, but reserved for renal failure, history of peptic ulcer disease. Chronic gout or hyperuricemia. When pain and stiffness persist in between the attack, gout has become chronic. Other cardinal features are hyperuricemia, uric acid will be high in the blood. Number 2, presence of tophi is the deposition of urate crystals under the skin in the subcutaneous tissue. That occurs more in the pinna, eyelids, nose, around joints and other places. And also deposition of urate crystals in the kidney. That is also a sign of chronic gout. In majority of patients, hyperuricemia is due to under excretion. Uric acid excretion kome jay. But in a few it can be due to overproduction. Chronic gouty arthritis may cause progressive disability and permanent deformities. So, when we are treating a chronic gouty arthritis, the drugs can be divided into two groups. One is uricosuric, that increase the excretion of uric acid, and the other is the basically uric acid synthesis inhibitors. So coming to uricosuric drugs, here the drug is probenecid. Probenecid is basically an organic acid. It was initially introduced in the market to increase the half-life of penicillin. Why? Being an organic acid, it uses an organic acid transporter protein in the kidney and inhibit the transport of protein, other organic anion proteins. As a result, what happens? The penicillin excretion is decreased in the kidney, that result in the increased half-life of penicillin. Now, it was found that it, on the other hand, it is also increasing the excretion of uric acid, and so they are helpful in the gout patient. So, it is a highly lipid soluble organic acid developed to inhibit renal tubular secretion of penicillin, so that duration of action of penicillin can be prolonged. It competitively blocks active transport of organic acid by OATP, that is organic anion transport protein, at all sites. This transporter protein is bidirectional, and no net effect of probenecid on excretion depend on whether the secretion or the reabsorption of particular organic acid is quantitatively more important. For example, net effect of probenecid is inhibition of penicillin excretion. Again, uric acid is largely reabsorbed by active transporter urate-1, uric acid transporter 1. Probenecid inhibits reabsorption and promotes excretion of uric acid and thus decrease its blood level. Now coming to interaction, they inhibit urinary excretion of penicillin, cephalosporin, sulfonamides, methotrexate and indomethacin. They inhibit biliary excretion of rifampin. Pyrazinamide and ethambutol may interfere with uricosuric action of probenecid. They inhibit tubular secretion of nitrofurantoin. Nitrofurantoin is an antimicrobial drug used in urinary tract infection. So, to be active in a patient of urinary tract infection, the urinary concentration of the drug should be high. But what happens when nitrofurantoin is co-administered with probenecid? Probenecid, they inhibit the tubular secretion of nitrofurantoin. So what happens? The drug concentration in the urine is decreased and so the efficacy in urinary tract infection. Pharmacokinetics, completely absorbed orally. Completely absorbed orally, 90% plasma protein bound, partly conjugated in liver and excreted by the kidney. Plasma half-life 6 to 8 hours. Generally well tolerated. Dyspepsia is the major side effect, common side effect. It should be used cautiously in peptic ulcer disease patient. Rashes and other hypersensitivity reactions may occur, but they are rare. কোথায় কোথায় ইউজ করা যায়? Number 1, in a patient of chronic gout and hyperuricemia. It is the second line drug adjuvant to the allopurinol. Allopurinol is the drug of choice. Allopurinol কি করে? Uric acid synthesis inhibit করে. So it is the second line drug or adjuvant drug to allopurinol. It gradually depletes urate pool in the body and lowers blood urate level. Arthritis, tophi and other lesions may take months to resolve. Colchicine and NSAIDs cover is advised during initial 1 to 2 months of initiation of the therapy. They are ineffective in renal insufficiency patient and they should not be used in patient with renal stone. Plenty of water should be given with it. It can be used to prolong penicillin or ampicillin action by enhancing or sustaining their blood level. Number 3, along with cidofovir. Cidofovir basically is an anti-cancer drug. It is used in CMV, cytomegalovirus retinitis in AIDS patients. Now, it is an antimicrobial drug. Now, this probenecid, they prevent nephrotoxicity of the cidofovir. Now, coming to sulfenpyrazone, is another uricosuric drug. It is a pyrazolone derivative related to phenylbutazone. Phenylbutazone is basically an NSAID. but neither having analgesic action nor anti-inflammatory action. It is although related to phenylbutazone in structure, but it does not possess any anti-inflammatory action, it does not possess any analgesic action or antipyretic action. It is a uricosuric drug. It inhibits tubular reabsorption of uric acid, equally efficacious as probenecid, and it inhibits platelet aggregation as well. Gone into disuse because of more gastric irritation. Lesinurad is a uricosuric drug, mechanism of action similar to that of probenecid. Now, it has been recently approved by US FDA as a treatment option for hyperuricemia either alone or in combination with xanthine oxidase inhibitor. Now, these were all about the uricosuric drug. Now coming to uric acid synthesis inhibitor, the prototype drug allopurinol. So allopurinol basically they inhibit xanthine oxidase enzyme. What does xanthine oxidase enzyme do? Basically the hypoxanthine is converted to xanthine to uric acid by the enzyme xanthine oxidase, and thus they are helping in purine metabolism. Now, allopurinol is a hypoxanthine analog synthesized as a purine antimetabolite for cancer chemotherapy. No anti-neoplastic activity is noted, but was a substrate as well as inhibitor of xanthine oxidase. So, it acts as a substrate for xanthine oxidase, it acts as an inhibitor of xanthine oxidase. Substrate মানে কি করে? Xanthine oxidase convert allopurinol to basically alloxanthine. Alloxanthine is again a non-competitive inhibitor of xanthine oxidase and has a long half-life. Okay. So, allopurinol is a short-acting half-life 2 hours competitive inhibitor of xanthine oxidase, but its major metabolite alloxanthine again produced by xanthine oxidase is a basically long acting half-life 24 hours and non-competitive inhibitor. So, xanthine oxidase here is inhibiting conversion of hypoxanthine to xanthine and xanthine to uric acid. Again xanthine oxidase causing conversion of allopurinol which is a competitive short acting inhibitor of xanthine oxidase to alloxanthine which is a non-competitive longer acting. Now, this basically allopurinol and alloxanthine they inhibit xanthine oxidase. During allopurinol administration, plasma concentration of uric acid is reduced, but that of hypoxanthine and xanthine are slightly increased. Since xanthine and hypoxanthine are more water soluble, they have a higher renal clearance than that of uric acid. Precipitation and crystallization in urine do not occur because of increased solubility in urine. Because of raised level of xanthine and hypoxanthine, some feedback inhibition of de novo purine synthesis may be seen. Pharmacokinetics 80% absorbed, not bound to plasma proteins, metabolized largely to alloxanthine. During chronic medication, it inhibits its own metabolism and about 1/3 is excreted unchanged and the rest as alloxanthine. Interaction, the inhalation of 6-mercaptopurine and azathioprine, probenecid shortens half-life of alloxanthine, while allopurinol prolongs half-life of probenecid. Can potentiate warfarin and theophylline by inhibiting their metabolism. There are higher incidence of skin rashes reported when ampicillin with allopurinol is co-administered. Adverse effects uncommon, but hypersensitivity reactions may be seen causing rashes, fever, malaise, muscle pain. They subside on stopping of the drug, but the drug should not be restarted again as serious reaction may be seen. Renal impairment increases the incidence of rashes and other reactions. Stevens-Johnson syndrome is a rare but serious side effect. Gastric irritation, headache, nausea, dizziness can be seen. Precaution and contraindication, liberal fluid intake should be taken up. Contraindicated in hypersensitive patients. During pregnancy and lactation should be used cautiously in elderly subject, in the pediatric subject and in patient with kidney and liver disease. Drug of choice in the chronic gout can be used in both overproducers and underexcretors, sorry. More severe cases of tophi and nephropathy also respond well. Renal stone patient যেখানে আছে সেখানে probenecid use করা যাবে না because more renal stone can be precipitated, but that can be used here. So infrequently used in India, less effective in low GFR and inappropriate in stone formers. Both uricosurics and synthesis inhibitors can be used together when body uric acid level is very large. Allopurinol therapy generally are used long term. Secondary hyperuricemia due to cancer chemotherapy, radiation, thiazide or other drugs can be controlled by allopurinol, not by probenecid. Can be even used prophylactically in these situations. Potentiate 6-mercaptopurine or azathioprine in cancer chemotherapy or immunosuppression therapy. Febuxostat is a newer, basically non-purine xanthine oxidase inhibitors, equally and maybe more effective than allopurinol. Rapidly absorbed orally, highly plasma protein bound, oxidized, as well as glucuronide conjugation occurs in liver, excreted by kidney. Plasma half-life 6 hours. Hypersensitivity reactions are rare, but the more dangerous side effect is hepatotoxicity. Diarrhea, nausea, headache, usual side effect. By inhibiting xanthine oxidase, potential to interact with mercaptopurine, azathioprine, theophylline should not be given with these drugs. It's an alternative drug to allopurinol, but should not be combined with it. In fact, in India, we more use febuxostat, but should not be combined with it. Can be given sequentially in case of intolerance, non-responsive to the drug. Not indicated in malignancy associated hyperuricemia. NSAID colchicine cover should be provided for initial 1 to 2 months while initiating febuxostat. Pegloticase, basically recombinant uricase, an enzyme which oxidizes uric acid to highly soluble allantoin that is easily excreted by the kidney. Administered by IV infusion every 2 weeks. It is used rarely for refractory symptomatic gout, immunogenic, very high risk of immunogenic reactions including anaphylaxis. Due to formation of antibodies, response gradually decreases with continued use. So, this is a caution. Allopurinol as well as uricosurics should not be started during acute attack of gout. কেন? যেটা আগে বললাম acute gouty arthritis এ কখনো uricosuric or uric acid synthesis inhibitors use করতে নেই, কেন কি it can enhance the inflammatory response. During initial 1 to 2 month period of treatment with these drugs, attacks of acute gout are more common, probably due to fluctuating plasma urate levels favoring intermittent solubilization and recrystallization in joint. This period should be covered by NSAID or colchicine. একটা gouty arthritis patient আসলে acute gouty arthritis drug of choice কি আছে? হ্যাঁ, drug of choice in acute gouty arthritis কি? colchicine কি NSAID? NSAID কেন colchicine নেই? হ্যাঁ, नहीं, তিনটি ড্রাগ ইউজ করা যায়। একটা acute gouty arthritis এ 3 drugs can be used: NSAID, colchicine and corticosteroids. The drug of choice is NSAIDs, although it is lesser effective than colchicine. Why? Because colchicine have got very high toxicity. It is for this reason it is the second line drug in acute gouty arthritis. Now the second question, side effect of colchicine. What are side effects? Huh? Mainly gastrointestinal, nausea, vomiting, diarrhea including bloody diarrhea, these are seen. Most common side effects with colchicine. Okay. Now For chronic gouty arthritis, what are the drugs can be used? पिछन देखिए so when asked, we should divide the drugs into two groups. One is uricosuric drugs and the other is uric acid synthesis inhibitors. Uricosuric drugs কি আছে? probenecid আছে, আর কি আছে? সালফিন প্যারাজোন আছে, গুড। আর ইউরিক অ্যাসিড সিনথেসিস ইনহিবিটরস কি আছে? অ্যালোপুরিনল আছে, আর কি আছে? ফেবুক্সোস্ট্যাট, ঠিক আছে, মনে থাকবে। রিউমাটয়েড আর্থ্রাইটিস পেশেন্ট অ্যান্টি রিউমাটিক ড্রাগস কি আছে বলো? মেথোট্রেক্সেট। অ্যান্টি রিউমাটিক ড্রাগস জিজ্ঞাসা করলে দুটো ভাগে ডিভাইড করবি, একটা হচ্ছে নন বায়োলজিক্যালস, বায়োলজিক্যালস। নন বায়োলজিক্যালস মধ্যে কি পড়ে? আইজাথায়োপ্রিন, তার আগে মেথোট্রেক্সেট, মেথোট্রেক্সেট, আইজাথায়োপ্রিন, আর কি আছে? সাইক্লোস্পোরিন আছে, আর কি আছে? সরি, পেনিসিলাম এখন অবসলিউট হয়ে গেছে, পেনিসিলামিন গোল্ড এখন ইউজ হয় না রে। আর হাইড্রক্সিক্লোরোকুইন অর ক্লোরোকুইন, লেফলুনোমাইড, ঠিক আছে। বায়োলজিক্যালস মধ্যে কি আছে? TNF-alpha inhibitors. Examples? নামগুলো মনে রাখতে হবে। Examples? infliximab, etanercept, adalimumab. বায়োলজিক্যাল এজেন্ট মধ্যে আর কিছু মনে রাখবি না, কিন্তু TNF-alpha receptor অ্যান্টিবডি নামটা মনে রাখতে হবে, because these are the most commonly used. Drug of choice among the anti-rheumatic drugs? Methotrexate. Good. Most common side effects of methotrexate? Common side effects of methotrexate? Oral ulceration, GI upset. Okay.